Hi everyone, it's Dr. Fox. Let's talk about renal vasculature. In this video, we'll discuss the segments of the kidneys and their blood supply. We'll also define lobes and lobules of the kidney, as well as outline the branches of the renal arteries. We'll discuss the renal portal system, and we'll discuss left renal vein entrapment syndrome with an emphasis on the tributaries of the left renal vein and the tissues they serve. So let's begin with the renal segments. There are 5 renal segments: the apical, the anterior superior, the anterior inferior, the inferior, and then a posterior segment, which would roughly align with the anterior superior and inferior. Now, each of these segments are defined by branches of the renal artery called segmental arteries. So that makes sense, at least in the name, right? 1, 2, 3, 4, 5 segments, 5 segmental arteries, and that is the typical pattern of branching. It is possible to have more or fewer, but 5 is what is typical. Now, these segmental arteries are end arteries, meaning they do not anastomose with one another, and owing to this allows for a surgeon to remove a part of a kidney, one of the renal segments, without being to the detriment of the other 4 segments. So a partial nephrectomy is possible, much like a surgeon can remove a part of the lung, a bronchopulmonary segment, because it has its own unique blood flow. The same can be done with the kidney as well. And just as the pulmonary veins would typically anastomose, the intrarenal veins also typically anastomose. And this isn't so much an issue for partial nephrectomies, because on the venous side, blood pressure is very low and it's very easy to ligate. So within a segment, we can break that or subdivide the parenchyma up into lobes. A lobe is a renal pyramid, which is the medulla, surrounded by cortex. So this would be all around on one side. Lobes can be further subdivided into lobules. And a lobule is a little less intuitive from an anatomical perspective, makes a little more sense from a histological perspective, and that is a little bit of the cortical arch that surrounds a single medullary ray. And these medullary rays are visible with light microscopy. I bring this up because you may notice just the patterns of arterial branching here. So let's follow this segmental artery. It's going to branch into an interlobar artery, and then an arcuate artery, and then both of these will branch into cortical radiate arteries, like so. A lobe is going to take up half of that and then go all the way around, whereas a lobule will be between 2 of those cortical radiate arteries. And I mention that because cortical radiate arteries are also known as interlobular arteries. So you'll hear these in both ways. The anatomical way is cortical radiate because they radiate out into the cortex, but you also hear this predominantly from histologists, but others as interlobular because it's a reference to those lobules. And so let's follow the entire branching pattern of the renal artery. We won't do this for every single branch, but we'll do it for every type of branch. So from the abdominal aorta at about the level of L1, we have the renal arteries going out into the hyla, and they're going to multifurcate into segmental arteries. And as we follow segmental arteries, you just follow this one, they're going to branch into interlobar arteries. So interlobar arteries are found between the medulla and the renal column. And these continue and they wrap around the base of the renal pyramid And when they do, we call them arcuate arteries. So if it's between the renal column and the medulla, it's an interlobar. If it's between the medulla and the cortical arch, it's an arcuate. Coming off of both interlobar and arcuate arteries are cortical radiate arteries, also known as interlobular arteries. So those happen at both places along the way. And at this point, we're really at the microscopic level, because we could visualize arcuate arteries with the naked eye, but cortical radiate really requires magnification. Those cortical radiate arteries give rise to afferent arterioles. So afferent arterioles are carrying blood into a capillary bed, and in the case of the kidney, there are specialized capillary beds called glomeruli. These are the capillary beds where we have the process of filtration, or turning blood into filtrate. And then efferent arterioles will carry that blood away, as we'll see. So let's take a look at this system. So I'll just kind of color in here. This would be an arcuate artery coming along. And then coming off of the arcuate artery, here is our cortical radiate artery. And branching off of that are various afferent arterioles. You can see that they're heading towards these masses of vessel, those specialized capillary beds called glomeruli. And these glomeruli are contained within a capsule, and so that capsule is collecting all of the filtrate that's being produced. Coming off of the glomerulus is an efferent arteriole, so that's coming out this way, and this gives rise to specialized capillaries that are going to surround the nephron. That's what these two structures are. These are nephrons. And so the two structures are peritubular capillaries. So peritubular, around the tubule of the capillaries. These are going to be involved in the processes of tubular secretion and reabsorption. So movement of materials in and out of the filtrate with the blood. And then there are also specialized capillaries associated with the nephron loop. The nephron loop is here. And we call these vasa recta. Vasa recta are straight vessels, and these are involved in the refinement of the reabsorption of water, as we'll discuss. So from the other side of these capillaries, we head back into venules, and the pattern of venous return basically mirrors that of the arterial supply. Now, at a very high level, so that was fairly granular. At a very high level, there are two renal veins. The left renal vein, so here is the IVC, the inferior vena cava. The left renal vein is significantly longer. It's 3 times longer than the right renal vein. The right renal vein is short, the left renal vein is long, and that's because the left renal vein has to get over the abdominal aorta. We can also see that left renal vein is being crossed by the superior mesenteric artery. So let me switch colors here. Actually, let me do it like this. Let me go back, and so this is blue. This is vein that's going out to the kidney. And here is the SMA crossing over that left renal vein. Now there are a couple of branches, or I should say tributaries, that feed into that left renal vein. This one, ascending from below, is the left gonadal vein. And this one here is a common trunk that's receiving blood from the left suprarenal vein and the left inferior phrenic vein. So let's think about this. On the left side, blood from the left hemidiaphragm, blood from the left suprarenal vein, and blood from the left gonad are all draining into that left renal vein. Whereas on the right side, all of those branches drain directly into the IVC. Now, here's where things get interesting. There is something called left renal vein entrapment syndrome, and I'm going to draw this in profile. So let's think about the relationship of the SMA to the left renal vein and the abdominal aorta. So if I draw a really large abdominal aorta, I know my drawing skills leave something to be desired. And then imagine, so this would be a lateral view, and then imagine that's the SMA coming out of there. Now, if, kind of in the crux of this, we have our left renal vein. If there is any sort of aneurysm, so an abdominal aortic aneurysm or a AAA, where the wall of the abdominal aorta begins to break down and bow out, what that does is it puts pressure on the left renal vein. And with that pressure, it prevents the return of blood from the left hemidiaphragm and suprarenal gland, the left kidney, and the left gonad. All of that builds up. And that's called left renal vein entrapment syndrome, also known as nutcracker syndrome. And this can present with a variety of symptoms. So hematuria, which is blood in the urine, flank and or gonadal pain on the left side, or left-sided varicocele, which is an expansion of the pampiniform plexus, which would be the veins of the left side of the scrotum. So there are a variety of symptoms that can of left renal vein entrapment syndrome. But it's interesting to think about these asymmetries of blood return from the left side versus the right side. Now let us assess our knowledge. Which part of the parenchyma of the kidney is adjacent to the arcuate arteries? Well, the arcuate arteries are between the medulla and cortical arch. Best answer, pyramid is a little too general because that's going to be alongside both interlobar as well as arcuate. So it's kind of a good answer, but it's not specific enough. Renal pelvis, no. Renal column, no. It's cortical arch is between that and the medulla is where you would find the arcuate arteries. Thank you so much for your time, and I look forward to talking to you in the next video. Bye all.